name is Shreya Prasanna, and I will be facilitating the session today. Unlike clinically focused echo series, in this space, we will focus on organizational and implementation challenges related to delivering substance use disorder services. Our goal here is to create a learning community to strategize around systems level challenges in substance use disorder treatment and programming. We'll follow our standard structure for these sessions, starting with introductions and a brief evidence-based didactic on a key topic related to SUD systems and sustainability, followed by some announcements. Following that, we will hear a systems case presentation from a member of our learning community, and we'll discuss it as a group. This is really the heart of all teach, all learn model of ECHO telementoring and the space for you to share your thoughts, questions, resources, and lessons learned with your peers and colleagues. Some housekeeping before we get started. We are recording these sessions for later distribution through our YouTube channel. Any info you put in the chat will not be shared on the recordings. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. If you've joined by phone only, note that we may call you after the session to confirm your attendance. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to join by video for the discussion portion of our session. Please note that no protected health information is allowed in either the chat or the discussions. Toward the end of the session, the BeWell Texas team will send out a link to an evaluation survey. Please fill it out to give us your feedback on how to refine and shape these sessions, as well as it gives you access to free CME and CNE. All participants filling out the survey will be automatically entered into a draw for a $30 Walmart gift card. Our didactic today talks about tools for organizational needs. Followed by that, we will present a case. It'll be presented by Anna Eisenberg. We'll do some introductions. Let's start with our hub. Matt Russo.
Hi, folks. Good to be with you. I'm Matt Rosa, background in NITEX process improvement, quality improvement. I'm a consultant who works in a range of implementation studies and quality improvement work. So I'm glad to be here with you today.
Thank you so much. Cathy?
Hi, everyone. I'm Cathy Hudgins. My background is in integrated behavioral health care and the former executive director of the Center of Excellence for Integrated Care. I am currently a consultant working with community health centers and other types of health and behavioral health organizations to put behavioral health and primary care and substance use treatment together.
Thank you. Leslie?
Hi, everyone. I'm Leslie Manson. My voice is going a little bit, but my background is in practice transformation, integrated care, and I will stop there. Thanks, everybody.
Thank you. Priscilla?
Hi, everyone. My name is Bidiseda Kotoa, and my background is in substance use treatment services. Thank you.
Thank you so much. Anna?
Hi, everyone. My name is Anna Eisenberg. I'm the OSAR Waitlist and Capacity Coordinator with Health and Human Services Commission with the Substance Intervention and Treatment Programs Group.
Thank you so much for joining us. Adrian?
Hello, Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring here at UT Health. Thanks.
Thank you. It is a small group here, so we'll do some introductions all around. Kelsey.
Hi, I am the collaborative care liaison at Karma Health here in Austin, Texas. I'm an LMSW, and I look forward to learning more about how to run systems and programs, because that's what I'm trying to do here. Thank you.
Thank you for joining us. Sean?
Hello, Sean Wright. I'm the Program Director for the Recovery Support Services Program at Abilene Recovery Council.
Thank you. Rhoda? I think Rhoda's connecting to audio. I will come back to her. Sanjuana? Sanjuana, are you able to unmute yourself and introduce? All right, we'll come back. Richard.
Hello, everyone. Richard Hamner with Be Well Texas at UT Health San Antonio Recovery Support Services.
Thank you so much. Rhoda Hall.
Rhoda is actually trying to get in. The strangest thing is happening. This is Carmen, her supervisor. I'm pulling up under her name for some reason. So I don't know what's going on, but I will get out and let her in.
Well, you can stay on too. Thank you
Okay.
for joining us.
Okay, thank you.
Yeah. And Sharon?
Yes. Hi.
Hi, can you introduce yourself?
Hi. Yes, I'm Sharon Shoemaker. Work with Abilene Recovery Council as on the Be Well Texas grant. And I guess that's it.
Okay, thank you for joining us.
Yes, ma'am.
Andrea Hebler?
Hello, my name is Andrea Hebler, and I'm a project coordinator for ECHO here at UT Health San Antonio. Thank you.
Thank you. Mark?
Hi, my name is Mark Ferris. I'm the instructional designer here at Be Well Texas.
Thank you so much. And James? All right. We'll come back to Jim. I think he has no audio. Anyways, we'll come back. It's time to move on to didactics. Cathy, whenever you're ready, you can get started. Thank you so much.
Can you all see that now?
Mhm.
Great. Hello, everyone. Welcome, and I'm so excited to be working with you all. Let's see here. I'm going to make sure I can get to the next slide. So today we're going to be talking about looking within our organizations for the needs that we may have in a post-pandemic world. We're all emerging, and we're finding that our patients and the providers and our organizational structures may have changed quite a bit in the last couple of years, and actually will probably continue to change. The information in this presentation, quite a bit of it is coming out in real time, as you know, from the literature, as we are starting to put things out into the public domain, as we survey what's happening. And the strategies that we're going to be talking about are also evidence-based. And since it is a small group, I would love for you all in the chat box to talk about some of the things that you are doing to help with the issues that we're starting to see as we survey. And we can exchange best practices and strategies as we go along. Let's see. I have no, relevant financial interests or any relationships to disclose. Our learning objectives. So after this presentations, you should be able to identify emergent post-pandemic substance use disorder and mental health service needs that are coming up in your organization and probably also in your community. And it looks like some of you all are doing more than just one organization. Summarize needed post-pandemic service delivery and organizational changes to meet those needs, and how organizations can identify short and long-term modifications to meet current and anticipated demands. So I'm going to just start. I feel like we're all at different stages of a post-pandemic sort of survey as the dust clears. In Texas, you all probably are in a different spot than some of us are in other parts of the country, but we're all seeing some very similar things that we may not have been seeing post-pandemic, pre-pandemic. And this photo, I hope this wasn't too close to your all's own experience with your tornadoes and things that have happened in Texas, but I feel like this is how many people describe coming out of this pandemic, where we're still in the middle of it, but we're seeing things sort of calm down a little bit. You know, it's a lot, and it's a lot to try to figure out what we should do first. Where do you start? And so as we survey, here are some problems that are consistently being reported, and they are being researched across the United States. And it would be interesting in the chat box for you to sort of note, are you also seeing these? First of all, statistically, we're seeing increased death rates for people with mental health and substance use disorders. And that really has a lot to do not just with COVID, but the lack of preventative care, treatment for chronic health diseases that may be related to their COVID disease states, but also maybe their substance use disorders, cancer that has not been screened or treated. And so there's on and on. We're having difficulty, parsing that out, but we do know that our death rates are increasing, especially for our mental health and substance use disorder patients, and also specifically, more so than anything, patients who are underserved, low income, and marginalized. We also have an increase in demand for behavioral health services, like we needed any more increase in demand, but it has increased across all populations, from children all the way to older adults, for so many different reasons, which also then puts a stress on access. You probably, I don't know if your organizations are seeing more demand, and then a request for things that have gotten to be at the crisis level, whereas they may have been treated prior to getting to that level. Higher rates of overdoses. I don't think that any part of the country is seeing a decrease in those, and that had a lot to do with social isolation, lack of services, discontinuation of services or disruption, and then an increase in use of alcohol, and not just for folks who have been diagnosed for a substance use disorder, but across populations, especially white males. The number of days of drinking increased by 50% within the first 3 months of the pandemic, according to one study. And now we have to try to figure out for people who have never been diagnosed, what type of treatment to help them with that level of use. Financial problems, and it's not helping that we're sliding into what looks like to be a potential recession. So increases in cost of living, decreases in employment, have created some additional social determinants of health complexities that we may have to help with. This also includes things like decrease in COVID support, and then the changes in housing laws for they had some protection for being evicted, and that is also changing. And so people are really in a very tenuous situation, many of them teetering on disaster. Healthcare, behavioral healthcare provider burnout and shortages. And again, we were already in a shortage, but we have people leaving the field. We have provider types of all kinds leaving the field because of the burnout and stress. And, this puts additional stress on folks who are currently still providing services or planning for services or helping people in the community. And then it just seems to be a cascade. We also have the revelation of health disparities. And this came up when we started looking at statistics of mortality rates and access to care. And we found that, we have the people of, our populations of color and our low income folks, and also our older adults, are really suffering. And then the increases in interpersonal violence and child abuse. And I put that in there too, because that has actually changed some of the dynamics in the way we help our patients, because this has gone unidentified because children are not in schools and patients were not coming in for preventative care. So gosh, okay, I'm from the South, everyone. All I want to say is bless this mess, right? There's a lot that we have that are strengths, but we also have quite a bit to deal with that may change the way our organizations deliver care and plan for future changes. This has a lot to do also with the way that funding is, some of the funding policies and the way in which dollars are being allocated for mental health and substance use. We may be able to capitalize on that as we make these changes, and keeping a clear eye on those is really important. So here's what we might want to consider. And this might help you as you survey your own, organization post-pandemic. How is your organization meeting the demands and those complex issues your patients are presenting? Are they coming in with more health issues, more chronic diseases that are not identified? Are they coming in with additional needs for housing support and for food insecurity? Are they coming in with, maybe co-occurring disorders? Maybe it was, you were treating and helping them with their mental health issues, but now they have a substance use disorder, or vice versa. What do we need to do with these patients who have now become even more complex than they were before? And do you have enough and the right staff to effectively respond to these patient needs? Are you able to then, not just patient by patient, one at a time, but actually identify a common need that would drive a change in your organization, or a service that you would increase or create a collaboration with another organization? These are things that you may have done one-on-one when, occasionally you would see a patient who had maybe food insecurity, but now you have 50% of your patients with food insecurity or the threat of being unhoused. What collaborative partnerships are in place to meet the whole person healthcare needs and address health disparities? We are no longer able to do this in a silo. Now, if you look at the way it was trending prior to the pandemic, we were moving toward deeper, partnerships and more collaboration between substance use and mental health treatment and organizations that help the whole person and our medical care, because we know that we get better health outcomes when we are treating the whole person in that approach. And if you look at this is the old Bronfenbrenner ecological model. Whole person care goes across all of those systems, all the way from the patient, all the way back out to policy. And a lot of times our organization is working in that gray triangle. If we are only working within our own organizational scope of practice, we may not be able to do what we need to do for patients. And because of the decrease in services, or even the inability for them to access treatment for medical, or access housing support or transportation, that puts additional burden. And a lot of times people who are in mental health and substance use do a really great job in that area, but our primary care providers are really needing support. So that goes by, both ways for us to be able to assist them as well. So those partnerships are important. What technology and related expertise do you have to keep up with telehealth trends? Now, I know this is one of the things you all talk a lot about, but people really became very dependent on telehealth if they had access. Apps have been created to help people manage their wellness, their addiction. We have online groups that we had to form because people couldn't be in the same room. And then teleconferencing. You all have telementoring, teleconferencing, helping our organizations work across, so you can actually staff high utilizing patients or patients with complex health needs across organizations through teleconferencing. And the challenge now, well, it was at the beginning, but we weren't quite sure. Is Zoom HIPAA compliant, and does it apply? Do we need these consents based on 42 CFR Part 2 regulations and for a substance use treatment program under the federal guidelines? But luckily, we were more nimble than we thought we would be, and more willing to actually take on those types of technologies. Now that the dust is cleared, we need to go back and see, and also because the regulations are now becoming more restrictive. They had been lifted a little bit in the penalties. Now we need to go back and see, do we have the policies in place? Do we have the training in place? Are we ethically providing that type of service according to these guidelines to help protect our patients and their information, and also to provide ethical care? And then how are you addressing staff burnout and loss of trained, valued members of your team? I know that one organization that I'm working with they were up to 150 staff members, they're down to 105. And turnover in all areas of this organization. It's a problem. We weren't able to really stop the presses and help with burnout. I assume that there were things that people were doing for self-care and giving their staff time off. But when you have an increase in demand, it is very difficult to meet that demand and give people the time they need to actually refresh. I think also in substance use and mental health treatment, we rely a lot on consultation and supervision and with each other to sort of unburden ourselves. And I consider it like reduce the residue that happens when you continually are taking in everyone's problems. And then also your compassion fatigue. It's so helpful to reconnect with your groups. But when you're in the throes of high demand, and also disconnecting because you're not seeing each other as much in person at the beginning, are you reconnecting? Let me tell you a quick anecdote. I was helping a medication-assisted treatment program, and they had a little bit of nurse practitioner work for health, and they wanted to increase that. So I'm sitting in their waiting room, and I couldn't tell. Some people were going straight into the area where patients were being treated, and some patients sat outside. And I thought, well, where is the staff? So when I ended up in a meeting with all the staff, what I found was that many of the staff I thought were part of the patient base. And it was because their whole demeanor and their attitudes and their whole, just feeling this weight on them. And also just a lot of, pushback. And I thought, why is this happening? And I talked to the director, and he said, I'm glad someone from the outside recognized it, because I'm experienced in this, but we had to give up our group supervision and consultation. And also, I just haven't been able to meet with each one of them individually to sort of help them through this. So I think they're actually reflecting their patients' feelings and behavior and taking that on. And I thought that was fascinating, because it's something when you're in a high, demand time, or when things are really stressful, that kind of support is really important for your staff. So I'm going to stop there for a second. Has anything that I have said resonated with any of you? Because I'm deeply inside many of these types of systems and helping them, but I get to separate myself and get back in the helicopter. I know Matthew is in the same, and then so is Leslie in the same position. But thoughts about any of the things, and I'll go back, of some of these things that we're seeing. You can put it in the chat box or open up your mic. This isn't, so not, maybe this is just the people I'm working with. This could be a bad sign. Maybe I should start making apple butter for the farmer's market.
We can open up the floor again, Dr. Hudgins, after you're done with the presentation. So
Okay.
maybe people can think about it a bit and then ask
Okay.
the question.
Well, the reason I really wanted to know that is because, I do want to go over some things. I want to actually, one of the things I'm going to focus the most on. And let me just say, as we go on, the hub team, we have talked a lot about the different aspects of program development, organizational change and development, and sustainability. Any one of those considerations could be a series, but could be at least be one session for our ECHO. I want to hone in on one thing that I'm seeing quite a bit in the substance use treatment programs I'm working with. Post-pandemic, and I said a little bit about this before, patients were really not getting their visits in with their doctors, especially if they had chronic disease, those comorbidities with their substance use and mental health diagnoses. And so they would, when they finally started coming back, we had one woman, and I want to point this out because I think you all know this more than anybody, but a lot of medical problems appear as mental health or substance use disorder issues, and they mask themselves. So we had a woman who came in and had not been in the office-based opioid treatment program because she was really terrified of the pandemic. She came back 6 months later when everything opened back up, and she was disoriented. She was very sleepy, nodding off. Immediately, they did a urine drug screen. Of course, that was part of the process, but they thought, oh, she's relapsed and we have a lot of problems going here. Actually, her blood sugar was so high, it was crazy. She was diabetic. She had her struggle with diabetes actually had been under control during her treatment, but during the pandemic, she had not been using her insulin. I mean, it was absolutely astonishing. But the first thing they thought was, oh, she's relapsed. Luckily, this program is in a primary care community health center. And so they were able to link her to a medical provider immediately and stabilize her, but also put her on a plan to get her diabetes under control. I mean, that's just one example, but other things that really could be, appear, and these are things that would have been caught in preventative screenings and health checks. And a lot of times mental health and substance use treatment programs do not routinely screen patients for their preventative care. I know that one organization, after that was in part of a medical system, reported 99% decrease in mammograms for their patient base during the pandemic in the first year. No one came in. We also have people who are not doing their colonoscopies. We have people who are not getting their vitals even taken, and their blood pressure is increasing. But, things that we would even look at, not just diabetes, but urinary tract infections, especially with our older adults, will look like psychosis. If they've not had their blood pressure checked, they could have a stroke, and we would know that. And we would not be able to understand if it was a mental health or a substance use issue. If they have if they are still or if they've taken on more alcohol use and have fallen, they could have a brain bleed, and that will look like basic mental health disorientation. Thyroid levels, those are the other ones that can be very difficult. And then thinking about the comorbidities that go along with substance use, oral health problems that lead to chronic health, chronic heart disease. We have coronary artery diseases that are associated with these. So there's multiple, and then high blood pressure, obviously, that's another one. Gastrointestinal issues, esophageal cancers. So we know that a lot of these things are going hand to hand. So one of the things that you might need to do, because there is a lack of providers and getting people into or have some connection to medical care, if you don't provide that as an integrated care site, is to maybe do a health screening survey. And there are lists of those that are age appropriate and then also gender appropriate that should be done every year. This may be part of your yearly screening with your patients. It could be something you do periodically, but it probably should be put in place, because then you could be able to get that coordination if you don't have it on site, in order to get them to those screenings or those assessments, in order to increase the quality of their life. Because you know that if they are, if their health functioning is higher, then they're able to work. They're able to actually participate more meaningfully in their substance use treatment and their mental health treatment. There is one that a lot of mental health and substance use treatment programs will use, and that's the Duke Health Profile. It does not really get at some of the like the specific health issues, but it talks a lot about health functioning. So if someone's falling, if someone is not feeling well, you know, a certain number of days of the week, then you're able to help them get to a medical provider to assess what's going on. I didn't list these, but and it's because health checks have not been validated as much as the behavioral health checks have, like the PHQ-9 in primary care. But there's the physical health check, the PHC, the health improvement profile, the HIP, and then Intermed is another one. So if you're interested, we may be able to even, you know, I do have resources I can send you, but we might be able to even have someone come on and talk about how to use those in your organizations.
Dr. Hudgins?
Yes.
Yeah, I apologize to interrupt you, but we're getting close to time. So if you could maybe take a minute.
Sorry. And then if your organization, in order to have a better relationship and to meet the healthcare needs, the whole healthcare needs of your patients, you may want to look at a needs assessment for your organization. The one that I've used most often is the MHAP, the Main Health Access Foundation Site Assessment. If we have a moment, I'm going to pull that up, but it has two main domains, the clinical and operational. And it breaks down your organization to identify your current collaboration in all the domains, such as universal health screenings in behavioral health, and ability to make referrals to other organizations for a different service line, such as Healthcare for You. And then also the pathways in order to get your medical records back into your record in order to take care of your patients. So it does give you, it breaks it down into these domains that you really could choose as strategic planning points and for your QI programs. The BICA is actually another one that a lot of organizations use. And this one in particular has 3 levels, and it assesses behavioral health organizations' readiness and capacity for putting primary care together. So everything from just basic coordination of that healthcare needs of your patients to co-located, which is the midway there, and then all the way to building your own healthcare service line. We have, and then the IPAT and the PIP, and those two really are just very short, just to see what level you already are in your integrated care between your primary care and your behavioral health. Just 2 things, organizational collaborative agreements. We know that it is BAA, the Business Associates Agreement, is an organizational agreement that you can have to exchange information if you are increasing your collaboration across organizations. If you are considered a 42 CFR Part 2 program under federal guidelines, then you would need a Qualified Service Organization Agreement, a QSOA. Though there's quite a bit of literature about those, but the SAMHSA website does a really good job also of talking about that. One last thing, staff assessment. You may want to do the burnout assessment tool. There's another one called the MALAC. I don't know if you use the MALAC burnout assessment. It's MALACH. I did not put that one here because the BAT, the burnout assessment tool, has been used currently probably more. The MALAC has not been used as much recently. It's a little longer. So, you know, just getting a pulse on how burned out are your staff and what should you be able to do. All right, so I don't think I have time to go through the MEHAP, but if we decide that we want to do an entire assessment on site assessment, I mean, an entire session, I'm trying to talk too fast, and as Southerners, we can't do that. So, we would be happy to maybe revisit that and also go through that with everyone. So I will leave it there, and thank you all so very much for listening.
Thank you so much, Dr. Hudgins. That was a wealth of information. Thank you so much for sharing that with us. We will now move on to announcements. Angela, if you could please bring up the announcement slides. Thank you so much. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for SUD throughout Texas. Next slide. The Be Well Texas Clinic offers low-cost self-pay and no-cost services for patients affected by substance use disorder. We also have insurance options available. Next slide. Coming soon, we have 2 new ECHO programs, the Public Safety ECHO for public safety professionals and first responders, and the SUD ECHO for behavioral health directed at behavioral specialists. Next slide. We will continue offering our TextRx, RSS, Shout, and Harm Reduction series with a new one-time registration link. It is very easy to have all our echoes in your calendar. You can register for any of our ECHO programs at bewelltexas.org. Next slide. Our next Systems and Sustainability ECHO is on Thursday, July 28th. Please do join us. Thank you. We'll now move on to the case presentation. Once ECHO IT brings up the case, Anna, please take it away. Thank you.
Hey, good morning or afternoon. It's afternoon. So I was going to present on it's not a very creative case, so I apologize for that, but it is an issue that continues on, and really, I think Cathy really hit the nail on the head with a lot of items, because I think we're seeing that the effects of the pandemic or post-pandemic, whatever we're in right now, throughout or at least that's what we're seeing throughout the field. So I'm just going to go through this, but if anyone has any questions, please feel free to interrupt me. So we were thinking of, when I was filling out this form, we were thinking of the OSARs, which I'm guessing a lot of you are familiar with, but if not, I will just very briefly give an overview of OSAR. So OSAR stands for Outreach, Screening, Assessment, and Referral. And these are programs that are provided in each region of the state. They're available to any individual who's interested in information about substance use services. And they also provide other services or referrals to other services. And they can typically be the starting point for someone who's interested in substance use services, but may not know where to start. So that is, I can provide more, I'll provide a link in the chat to sort of the statewide OSAR website, but that's a program that I oversee as part of my position. And so I've been in that role since about March oh my goodness, I almost said 2015. March of last year, which was 2021. So I know what time it is. So that is a statewide program. And so there are 14 OSARs. There are certain regions that have more than one OSAR serving the area, but they serve different counties in the area. And the only requirement to go into an OSAR essentially is to be a resident of Texas or be residing in Texas. So thinking with that in mind, when we were looking at the number of employees in the system, I typically interact with about 40 OSAR program directors. I know that they are embedded in local mental health authorities and local behavioral health authorities, depending on where they are. But I speak to probably about 40 program directors throughout the state who provide OSAR services. And the distribution of healthcare professionals question, it's primarily LCDCs who are providing the OSAR services throughout the state. In terms of my desired outcomes, ideally in a dream world, individuals would be made aware of the OSAR services via some type of outreach, some type of referral, some type of community provider, giving them that reference point and saying, this is a service that's provided throughout the state, and you can go here for these types of services. And then after that, after they hear about the OSAR, then they are screened or assessed by the OSAR as appropriate, and then referred out to the most appropriate types of treatment. It can be different, it can be multiple types of treatment depending on client interest and need. So if they meet certain clinical and financial eligibility requirements, they can be referred to substance use treatment. And that's my dream, is that sort of everyone eventually gets into that substance use treatment that as appropriate, and then sort of hopefully move along, and if they need the OSAR support again, then they know where to go, and they've navigated the system. In terms of funding, HHSC receives funding from SAMHSA, and then we distribute that funding among 14 LMHAs and LBHAs that are in which the OSARs are integrated. So I checked primary mental health here because they are co-located in those LMHAs and LBHAs throughout the state. And then my category that I selected, I think workforce development is probably the most appropriate, because that is a big issue that we're seeing and haven't found a great solution for. And I will provide a little more details. If you wouldn't mind scrolling down a little bit. I'm sorry, thank you. Right now, I think we're still sort of in the assessment phase. So we're assessing needs. We're trying to figure out exactly what would be useful. There are a lot of limitations that everyone is working within. So I think that's the thing that sort of is most difficult, is these sort of barriers that I haven't figured out how to address. And we've had a lot of brainstorming sessions, a lot of ideas, but they have not necessarily yielded the types of results that we are hoping for necessarily. So in terms of my challenge, so there, as Cathy was talking about, there are large scale workforce shortages throughout the state. I think in every, I've seen so many, I think in every sort of facet of work and labor, I think you can go and see those hiring signs everywhere. And it's particularly difficult when they're trying, from what I've heard, particularly difficult when they're trying to fill LCDC roles and positions that have been open. They've also reported that experienced LCDCs have retired or are retiring or leaving or experiencing that burnout that Cathy also described, and then leaving the workforce or moving on to another position. And then development and training have been delayed for new LCDCs because of the pandemic and because things sort of shifted, and I think sort of everything was delayed. So there's also difficulty because they have been given, they have a certain pot of money. They can only use it, they have to provide a lot of services with that pot of money and may not be able to compete with higher salaries of other entities. I think we've seen a lot of people raising their salaries or hourly wages in an effort to compete, and that's still, I think, posed a difficulty because I think you're seeing that everywhere. And there are a lot of remote roles, and some of the roles that OSARs have are not, you're not able to be remote. So there's just it's just a very competitive market for workers. I don't think any of this is new information, but it's really affecting, I think, our OSARs. So specific factors, I've mentioned some of these, so that statewide workforce shortage, filling LCDC vacancies is pretty difficult, especially I think in rural areas. We've heard it as being more difficult. The OSARs do receive level funding. We did get some COVID funding, but it isn't necessarily for workforce. It wasn't specifically for workforce, and it was specifically for other purposes. So that hasn't helped in that area. And I think there are some programs, with the increased need that Cathy also referenced in the community, there is an increased need for these services. And so when you have a program that's growing, but their funding stays the same, I think that's pretty difficult to meet that demand. And then the COVID pandemic, of course, has delayed so much of the development and training of new LCDCs in the workforce, affecting sort of every facet of life. So in terms of key strengths, I think the OSARs have done a great job with leveraging resources as much as they can. They report sort of developing or building internship programs, strengthening relationships with universities to develop those interns. And I think that has really, that's been sort of the strongest way that they've been able to leverage those resources. We continue to brainstorm and try and come up with creative solutions, but I just don't think we've gotten there at the state level. I think we have a lot more to work on. And then increasing awareness of licensure opportunities, vacancies, methods for staff recruitment and retention. I know people have talked about signing bonuses for staff that refer people who eventually get hired, and that internship program sort of as a pathway to employment for filling those vacancies. So, and then, yeah, like the successful implementation, I think that collaboration with universities, and really trying to go the internship program to sort of create a pipeline to employment has been the most successful from what I've heard from people in the field. So we continue to try and work on these like resolutions. If we hear about an individual situation, if an OSAR says, we have this vacancy, we've really been trying to fill it, what do you recommend? I think we try and brainstorm, but a lot of the times they've already thought of what we come up with, and we try to also create forums for them to share solutions, because that has been, I think, the most useful. I think if this challenge was resolved, everyone would be fully staffed, all the OSARs would have full staffing, and then they would also be able to retain staff for long-term periods, which I think is really useful. So my question was sort of, have you experienced this type of shortage? I think we're sort of seeing it everywhere, but how are you addressing it in the absence of additional funding that would be probably very useful in terms of recruiting and retaining staff? So sorry, that was a lot, but thank you for listening.
Thank you so much, Anna. I'll now open up the floor for questions. Matt, you wanted to say something?
I was just thinking of if folks are having, I mean, it's a challenging loop that many of you are experiencing, and the times when you need resources the most because of these challenges you've been dealing with are the times when you feel like you have them the least. The metaphor that comes to mind, it's like a 40-pound medicine pill. When you're the sickest, you have the hardest time lifting it to take it, and that's the time when you need it the most. And so there's this loop, right? And I'm just wondering what strategies you've used, because you're having increased demands, decreased staff, which increases the demand on your decreased staff. And where do you find a spot where you can just sort of try to stop that loop, even though it's super challenging? And I'm curious about where people have kind of made their stand. Like, here's a spot where we're just going to try to do something, even though it's super hard to do it. That's what I'm curious about.
For what we've seen, I think a lot of it has been that internship program, and that has been the biggest success that we've heard about, but people have tried a ton of different strategies. So if anyone has any strategies, we would sort of love to. I agree that there's this kind of loop or just a cycle that we sort of can't seem to get out of, especially in the rural areas where the resources are diminished anyway, typically. So I'm just curious about people have what people have done, because we have not come up with the solution that has really helped. They've really taken it into their own hands at the OSAR level, and it's just sort of, it's frustrating for us, I think, at the state to be like, these are the resources we have, but it's definitely not enough, and it's not, we're not providing the support, I think, that we would like to.
And this is sort of a this won't necessarily address that problem, but to reduce, to increase the ability to get at least EAP for folks, because that becomes a problem because you have then the increase of access because the patients need that. And so they decrease EAP when you do have that. Two rural FQHCs that I've worked with actually did a provider exchange for EAP. So they actually saw each other's staff via telehealth. And so it increased the ability to address and prevent burnout and help them without putting a strain on their own resources that would take away from their patients. So yeah, it still took a little bit of time off, but it actually helped support because you can't treat your own people. Most people won't. And so it did. That provider exchange was absolutely valuable.
That sounds great. Thank you. That's really interesting. That's a great idea.
What about, Anna, the use of the Clinical Training Institute, which are, kind of the school for the LCDC intern that are embedded in community-based organizations that are willing to, but that whole process of becoming licensed and going through Health and Human Services to get that license, pay those fees, and then to kind of grow their own LCDCs in-house, especially in rural communities, that could work. But has the state thought about incentivizing that with providers somehow, so that the providers have something, because it requires a lot of time for anyone who is providing the supervision. It requires weekly supervision, monthly, an LCDC or a qualified credential counselor on site. It requires a lot of resources. And has the state looked at the current CTI requirements to include not only that, but maybe revisit the number of hours required for each of those levels, like, level 1, level 2, level 3, and, what all of those requirements call for, because it really, puts, you almost have to dedicate someone full time to be the Clinical Training Institute coordinator. And I've done that job. So it's a huge responsibility, because you're helping, teach these new professionals to become fully licensed, and you have to make sure that they are learning all of the A's through Z's on how to do that. That's a thought, maybe like the state looking at that and maybe reducing those hours. Also, on the mental health side, they have a lot of resources for staff. On the SUD side, as it relates to peer support specialist, recovery support specialist, LCDCs, they don't have as much of those so-called like mental health days that they call that staff, encouraging agencies to do that, to prevent burnout. Right now, peers, recovery support staff, LCDCs have been front and center. They're the ones dealing with the crisis with the pandemic that we recently we're still in it, I guess. That takes a huge toll on staff, and, again, incentivizing that and encouraging agencies to, and showing them team building activities that could work, or having an hour every day where the staff could get together and have a safe place to vent and talk about something that happened during the workday. Again, because the stress is so high for this staff that are peer recovery support staff, recoveries that are out in the community and then come back. There's so much involved for these type of staff that I don't think they get as much support as they should or could. And the LCDC, of course, included. And has the state looked at what can we do from our end to reduce some of those barriers, reduce some of those requirements, but not compromise the quality, of course.
Yeah. And a while ago, I heard about the idea of reducing hours and reducing some of the requirements, but I think I'm not exactly sure where that landed. And that's a great question. So I can follow up on that and see where things are at with that and I know some of the long-term solutions feel like they're going to take so long that will we even see I'm sure it would create an improvement long-term, but I think in the interim, it's so hard to imagine anything moving quickly at this date. But I think that if we get started on it, but I will definitely check in on that. But I do love the idea of somehow providing more support. And if it's okay with you, I may follow up with you on offline about what they're doing on the mental health side a little bit more, because I'm less familiar with that for sure. And if that seems to be working, then we can mirror it if we are able. And I think that these are great suggestions. And I've written them all down, and I may follow up with you to set up a meeting if that's okay.
Yes, sure.
Thank you. Thank you so much. These are all great ideas.
I see the chat bursting with a lot of ideas and a lot of thoughts from everybody. Leslie, did you want to elaborate a bit if you want to? Otherwise, we'll just read.
Yeah, sorry, everybody. My voice is kind of a little bit in and out, but one idea that came to mind as folks were discussing is there are state initiatives out there that have supported, especially in rural areas, for the training of their own employees. So people that are already working for you, they've actually paid for their training for a variety of health, specifically healthcare needs gaps areas. They've even done education and paid for education for people to become PAs and NPs. So large scale, larger degree costs and lower degree and certifications as well. So it's wherever the gaps are and that you need, and it's part of a training grant that's a collaborative between the state and specific universities. And then the person who is put up for that or recommended, they sign a contract that you'll remain employed for a minimum of 5 years after they pay for you to do all of that. So that sometimes is really helpful for workforce development and consistency. Also put a shout out for other things like the loan repayment programs that really help supplement salaries, even though that's not their intent. That is what they do. They do provide federal tax-free cash money that people can utilize to repay loans, and that can help supplement salaries often to keep a workforce in place. And a lot of people don't know it's there. So having that to know, oh, it's an additional 20 to 50,000 a year can be a great benefit for people if they need that. So there might be some other things there too that are just unique.
Thank you so much, Leslie. In the interest of time, we'll try to wrap up the case now. Bree, could you just provide us a summary of recommendations?
Yes, so Anna, it sounds like there is that initial steps being taken to look at this problem, which has been growing, it seems like, for a few years now and isn't going away. So there's been some ideas that have been presented today that I think you can take back and look at, whether that is looking at it from what can the state do, but also there was some ideas on partnering up and collaborating, some of the ideas with providers and EAPs and some of what Leslie just mentioned. All of those are ideas that are on the side of providers or community-based organizations, but then also some homework for the state to kind of take a step back and look at. But it sounds like it's headed in the right direction. It just needs to continue to be looked at And maybe the idea of setting up a meeting where there are state personnel and community organizations across with varying from rural to urban to have input on this problem and what they're seeing and how to come up with ideas that can address the state as a whole, because this is a statewide problem, is my understanding. Is that right? Yeah.
That's correct, yes.
Okay.
Thank you so much, Bea, for that summary. Thank you, everyone, for joining us today at this ECHO session. This was a wonderful discussion. As a reminder, to earn a CME and CNE credits, please complete a post-session survey using the link in the chat. If you'd like to present a case, please email bvaltx@utisca.edu. We look forward to seeing you at our next session on Thursday, July 28th. Have a wonderful rest of your day and happy summer. Thank you.